Good afternoon, ladies and gentlemen, on our virtual platforms. On behalf of the Western Regional Health Authority, Mental Health Unit, the University of the West Indies, Department of Sociology, Psychology, and Social Work, Western Jamaica Campus, the Ministry of Health and Wellness, and the Pan American Health Organization, permit me to welcome you today for our Mental Health Week conference. May we remind you of our theme this year, investing in mental health. The time for action is now. It's never too late. My name is Georgia Rose. We want to remind all our guests to like, subscribe, and share. Also note that we continue into Saturday and Sunday. On Saturday, we will observe World Mental Health Day with a continuation of dynamic presentations from mental health advisor to PAHO, Dr. Claudine Cayetano, followed by a panel of esteemed specialists in mental health and wellness. On Sunday, we will conclude with Professor Benedito Saracino, past Director of Mental Health and Substance Abuse of the World Health Organization. Please be reminded that on Sunday, we commence at 11 a.m. We also want to remind the clinicians who are present in our midst to contact us to access their CME credits. This afternoon, we turn our focus to child and adolescent mental health, aptly guided by Dr. Terence Bernard, consultant psychiatrist at the Kingston Public Hospital. We have a wonderful lineup this afternoon with a team of esteemed personnel who have a deep love and passion for child and adolescent mental health. Dr. Bernard?
Good evening, Georgia. Thank you very much for that introduction and welcome everybody to this evening's presentation. I am your moderator for this evening, and our guest speaker this evening is Dr. Ganesh Shetty. Just a little bit about Dr. Shetty. Dr. Shetty is a child, adolescent, and adult psychiatrist, and also a child and play therapist. He is also a clinical supervisor. Although he was not born here, he is one of us, a naturalized Jamaican, and he has been working in our government service for many years. He has worked in child guidance clinics in the region, the Southeast region, and of course he has affected the schools and the community. And he also works at the University of Technology, where he impacts the lives of these adolescents and young adults, and he also has a private practice. After the incursion that occurred in West Kingston in 2010, Dr. Shetty, with his colleagues, has helped over 200 children of those affected communities with post-traumatic stress disorder. And in collaboration with NGOs, Dr. Shetty and his team have trained community-based youth workers and teachers to deliver trauma treatment in inner city communities and schools, including Augustown. Recently, he also played a significant role in starting a Saturday clinic for sexually abused children of children's homes at the Comprehensive Health Center. And since COVID pandemic, he started child and adolescent telemental health services in the Kingston and St. Andrew area health department. Dr. Shetty strongly believes that if we can unite by shutting the red eyes and transforming the bad minds, there is no challenge we cannot overcome with their creativity and ingenuity. And so we would like for you to give your attention to Dr. Ganesh Shetty, who is going to be talking to us about reducing adverse outcomes in adulthood and taking care of our children. Dr. Shetty, please welcome and thank you very much for being here.
Thank you very much, Dr. Bernard, for the kind introduction. I'm going to see if I can share my slides. Good evening, brothers and sisters. One love, one heart, one destiny. Today, we're going to see how we can create a situation where children can grow up in a happy and healthy environment and become functional adults and contribute to the society and become their best selves. I'm going to share my screen. And the saying goes, it's always good to build children, then wait and repair the adults. And we cannot not deal with children, because if we don't catch them in preschools, they will start to give trouble in primary schools. And if we allow them to continue without any help, they might land up in more trouble in high schools. And some of them, unfortunately, may not make it to college. Some of them might get into trouble with drugs and law and so on. Everybody's seeing my presentation? They say it is the time for new normal, but life was never normal when you see so many atrocities being committed against children and adolescents. However, we have new problems because of COVID-19. Recent research shows that home may not be safe for many families who experience domestic violence, as it impacts both intimate partners and children. And of course, the economic devastation, disconnection, and drying down of support system can cause a lot of tension, uncertainty, and panic. But we have a COVID-19 imposed on CRIVID endemic, which is crime and violence disorder, where we see a lot of children along with a lot of adults being slaughtered on a daily basis. And I think the death toll of CRIVID endemic exceeds COVID pandemic at this point. And we live in a monetary, military, missionary, materialistic system, and government is doing its best to balance economy and safety. And we have to try our best to keep ourselves safe and help as many as we can. So let me skip that. When we look at the dysfunctional adults, we look at what are the things which might be fueling those problems like crime or violent behavior, alcohol abuse, teenage pregnancy, unemployment, mental illnesses, suicide, and such. And also increased occurrence of diabetes, cancer, heart disease, substance abuse, and other severe mental disorders in adults. We can identify 4 factors definitely contribute to that. One is poor parenting skills of their parents, poor psychosocial support they receive growing up, and adverse childhood experience and trauma, as well as unidentified and untreated mental disorders. However, if you can look at the crisis and take it as an opportunity, we can probably take a JOSO and clear off gangs and guns, and coming off the grid with solar and wind powered energy, harvesting abundant water, growing, consuming, and selling fruits and vegetables, rearing, eating, and selling goats, pigs, and fowl, meeting, sharing, and enjoying on weekends together as a community, going out and working for additional cash. JOSO will not be a JOSO. It will be a tight-knit community with happy residents. So let us look at the 4 fueling factors. Poor parenting practices, corporal punishment is culturally condoned, and children should be seen, not heard, in some cases not seen either. And we have the issue about barrel children, where they have parents gone abroad for better life and only send barrels, and they connect with them very less oftenly. As well as we have children becoming parents, like teenage pregnancy, and 8 out of 10 children do experience some violent form of disciplining. Poor psychosocial support, poverty, 1 out of 4 children in Jamaica live in poverty. This is what UNICEF says. And it is more pronounced over female-headed household, which is almost half or more. And these children have substandard water and sanitation facilities, are likely to be younger parents, and they are not have fathers who are present in their life in the formative years, and of course, often get good lick as a more way of discipline. And that should definitely affect the quality of life, especially when somebody is supposed to protect you, violates you, physically abuses you, or emotionally abuses you, saying things like you're ugly like your papa, then it will affect the attachment, affect the growth of their body and mind, as well as it affects their self-capacities, capacity to connect with others, capacity to feel worthy of life, and capacity to manage their emotions. So there's a concept of adverse childhood experiences, which includes all kinds of abuses and neglects, as well as exposure to domestic violence, somebody in the house using substances, somebody in the house having mental illness, and parents separated or divorced, and one of the household member has been arrested. And now they have added some more to this: poverty, living in a community which is infested with violence, as well as being subject to discrimination like colorism in Jamaica, being sent to foster homes or children's home, as well as being bullied in school, have been added to adverse childhood experience. So what happens to those who are exposed to adverse childhood experiences? They will have significant risk of developing mental problems, substance abuse problem, and the physical problems also exacerbate their risk for physical issues like diabetes, cancer, heart attack, and so on is also significantly increased. So they may not make their potential and might not succeed in life in spite of having talent and intelligence. And last factor, trauma, is very well all over the place. There's no place to hide. It's there in home, it's there in school, and it's there in the community. And we have Jamaica proper, and we have Dominica, which is part of Jamaica, which is ruled by Dons, and there are different rules there. And many of these people the children living there don't go to school. And if they do, they drop out often. And there are children living and working on the street, and children locked up in so-called juvenile detention center. And they are in house arrest. Before, it was fear-induced, like if you're in a city dweller, you will not send your children after a certain time to go out and play because you don't want them to be caught up in violence. And if you're uptown, you don't want your nice little boy to mingle with butos. And they struggle with their identity. They wonder if they're white enough, black enough, fat enough, thin enough, sexy enough, or Christian enough. And the role models they have are not the best. And now we have invasion of virtual world into our houses and bedroom. And often children can get involved in it, addicted to it, and be victimized by the predator on it. And why it is so important to identify and treat mental disorders in children? Because 15% of world children do have mental disorder at some point. And half of all mental illnesses in adults begin before the age of 14, and 75% of them start before mid-20s. So it's best to catch them early and treat them aggressively. And half of them will have a serious disorder. And the burden of disease is very significant, and 1 out of 5 adolescents will experience a mental disorder. Self-harm is the 3rd leading cause of death in adolescents, and depression is a leading cause of disability. So what are the general complications? They don't do well in school, they don't hold a job, they don't relate with people well, and they might use substances. Medical problems are extra, medical service usage is extra. So basically they experience social occupational dysfunction. And if it's specific to attention deficit hyperactivity disorder, they might have oppositional defiant disorder growing up. And if unchecked, they might even develop conduct problems and substance use problems. And some of them might get into a life of crime and violence and develop antisocial personality disorder. And if they're smart enough, might even lead a country, and be a lot of trouble. Depression can be chronic, and suicide is a little complication of it. Anxiety and PTSD can also follow you right through your life. And somatophore disorders go to clinics so often and nobody can find out what's physically wrong with them, and they exert a lot of expense. So if you can calculate, we have about 800,000 children living in Jamaica, and about 300 are less than 10 years old, and about 500 are more than 10 years old. And even if we take an average of 15% and 5% being serious mental disorders, it works out to amongst 10 to 19, about 70,000 of them might have a mental disorder, and 25,000 might have a severe mental disorder. And the younger group, 45,000 might have a mental disorder, and 15,000 of them might have a severe mental disorder. Aggregate, about 120,000 children in Jamaica might have a mental disorder, and 40,000 of them might have a severe variety. So, so to help them, we have about 20 child guidance clinic sites, and about 16 clinicians work exclusively with children and adolescents. Approximately 50 clinicians with responsibility for large numbers of mentally ill adults try to do as much as possible to help out. And the data in 2018, we had about 13,300 sessions kept, and we helped about 3,500 children. And on an average, they had about 3 to 4 sessions, which is not adequate if it's a chronic disorder. And 35 to 40% of them did not keep the appointment. And this group had a lot of boys and teenagers who had behavior disorder like attention deficit conduct and post-traumatic stress disorder. And they are more likely to get into trouble at law. And to summarize the limitation of medical model, once they come to you and keep the appointment, it works excellent, because we have some really dedicated and very prolific clinicians amongst us. But those who don't come to us and will never come to us will never be helped. And that will be more than 95% in some cases. So what kind of diagnosis we give them in our clinics? Attention deficit hyperactivity disorder is common. Conduct disorder, post-traumatic stress, learning disorder, and intellectual cognitive disability, which is to be called as mental retardation. These in red have more connection with violent behavior. Not every one of them will exhibit it, but comparatively to other disorders, they are more associated with aggression, anger problem, and such. Abuse has been very significant in numbers, as well as depression and substance abuse. And what are the barriers? Why we are seeing only small amount of children is because we have understaffed and overburdened child guidance clinics. In Kingston and St. Andrew alone, if we kind of maintain a decent proportion from clinicians and clients, we might need about 5 more clinics. And we just have 2 in government system. And stigma, many parents think that my child is bad but not mad, so why he has to go to psychiatrist. And many of them cannot afford bus fare, and sometimes they had to go through violence-infested areas, so they're afraid. And some of them have temporary jobs. Taking time off work is difficult. Many of these disorders are chronic, and treatment is time consuming. So when miracle they expect don't happen, they stop coming. Poverty makes them have different priority, like feeding the children rather than taking them to the clinic for that day. And parents who are not supported, fathers who don't mind their kids, and school and community don't understand and help them, lack of positive role models. And we have social systems which are compartmentalized. We are trying to help mental part, somebody else is trying to help another family with social part and part program and poor relief and such. And we don't have long-term multimodal therapies with interagency coordination collaboration. And the usual barrier which has been spoken about is money. But this research from Dr. Watt in 2014 showed that we incur a cost of 8.6 billion per year because of non-accidental injuries or violence-related injuries, and 3.6 billion direct costs and 5 billion indirect costs. By the way, the budget of last year, apart from paying our salaries, a combined budget of Ministry of Education and Health was about $5 billion. And conventional treatment is psychotherapy in a group, family, or individual setting, medication, whether it's inpatient or outpatient setting. But what it fails to recognize is that the bridge of life, which children need to traverse to go on to become adults who are happy and healthy and contributing to the society, is broken. Parenting, school, and community is broken, and they're falling through the crack and becoming victims of drugs, crime, teenage pregnancy, and such. And we have Child Guidance Clinic helicopter, they're trying to rescue some. Child Development Agency, CPFSA, is trying to pull out some. It's the speedboat. They're expensive, but can't reach many. And the treatment has to be comprehensive. And these are some of the important disorders WHO has recognized. And you see, they need not just medication, but therapy, school intervention, family intervention, and such. So what we're going to do to reach more children in a more efficient way and try to help more children and their families and get better results. We have to change our approach. We have to change our approach from clinic-based, which is try to help those who seek help. They refer to us and walk in and hope they show up the next appointment. And 2 out of 5 instances, they may not. We have to move into family, community, and school-based approach where we try to find people who can help them, train them, and then find other people who can help them. So we might have to use all different modality, play therapy, and now telemental health approach. And we might even need some mobile telemental health approach because many of the children we're trying to reach don't have data. So we can only do telephone, not video conferencing with them, which is more natural and more helpful. And we had to, we used to do therapeutic summer camp and beach therapy like some of these girls are enjoying there, but COVID kind of threw a wrench in it. And the new approach is called system of care approach, integrated service delivery. We have to treat them resiliency skills to help them to take care of their body and mind and not to consume too much TV, Facebook, Instagram, and connect with family and friends, particularly in this season of isolation via virtual medium. But to help them to stop unhelpful thoughts, improve management of intense emotions, and increase social skills and pleasant activities. However, to get at least 20 clinics which are fully operative Monday to Friday and fully staffed with at least a psychiatrist, social worker, psychologist, and a mental health nurse practitioner, mental health officer, would be helpful to even help 1 out of 3 children in our target population. And for that, all funding agencies have to be knocked on the door, and all ministries have to come together and pool our resources to come up with an intervention which helps. So that means at international levels, PAHO, WHO, UNICEF, EU, they are helping us in many ways. UNICEF helped us through Ministry of Education with telemental health. And we have to advocate, seek assistance. The funding has to be flexible, of course, with oversight. And community intervention, different agencies which do help children in difficult circumstances should be targeting to those families who need it most. And it should not be like we are trying to help the mental health component and they don't have food to eat and they don't have busway to come to us. And it doesn't make sense to replicate. Ministries of Health is doing a parenting thing and Ministry of Education has a National Parenting Support Commission. So we have to allow and assist the experts to do their part. And of course, different agencies have to share tasks and to shift tasks, which is difficult in a collaborative and cooperative spirit. Agencies and school, we have school-wide positive behavior interventions and support program, which is flagship program of Ministry of Education, which has been piloted in about 60 schools, and they are thinking of scaling up. And they have come with a booklet which says how we can integrate service delivery, basically modeling the wrap-around approach. And they have also trained many clinicians as well as educators in mental health curriculum for schools where they can find children get comfortable with certain people who know what to pick out and where to refer them and how to support them. And other proven interventions should be welcomed because there are always more children we can help than we can ever help. And the training and intervention has to be shared by the universities, including Western Campus and University of Technology, as well as we have a Caribbean Association of Child and Play Therapy, which I'm a managing director, and we are trying to put together a collaborative approach of training. We call it learning collaborative, and it is different in a sense that it's not traditional teaching theory, but it's problem-based learning. That means you should have a set of patients you'll be working with, and you learn and apply what you learn. And it's also training the trainer cascade model, where who we train will go and train their colleagues in their clinics. And we do have experience in West Kingston, how we can intervene using different approaches, different interventions at different stages after a disaster, whether it's man-made or natural. And what we need is staff, people who can do the work. And we need at least a medical officer, psychologist, social worker, and 2 mental health nurse practitioners or officers, and 2 psychiatric nursing aides from each region for this to really work. And I'll just tell you what we're going to do. They need to be supported with time and incentives. And we have a plan how we can implement it. Although, as I said, COVID has postponed everything, including this. And it's a 5-year intervention, which is put in a phase-wise, where we'll help children who are traumatized, as well as those who need long-term intervention with chronic disorders. And we involve team from the clinic, team from the school, and team from the community, and they are trained to do whatever they can safely and effectively in their sphere of influence. We can also train community workers if it is incentivized and have them to do some case management. And CHJP has done a wonderful job in reducing violence risk by case management approach. They even have a book for that, their experiences. And I'm not going to go into details of this thing. Basically, it's about stepwise, phased approach in training people in the community. People in the community are trained by people in the clinic who are trained by the faculty who are experts in the areas. I have gathered about 15 people who are willing to be part of this. 10 of them are Jamaican experts in different areas, and 5 of them, 3 from US and 2 from Canada. And this is what's going to happen ideally. We will be reaching out about 540 children per region within a span of a year. So that will be nearly 2,000 more at least children covered for the year, just with this intervention, which involves training as well as practicing what you're trained in. And of course, it will be supervised by faculty, and Ministry of Education and Health will be providing some oversight. So, how the oversight and evaluation can take place. So we can target those factors which fuel dysfunction in adulthood if we can catch them early and intervene effectively. And we cannot do it alone. We need help of other agencies who happen to have expertise in their area. For example, parenting skills. National Parenting Support Commission should play a big role. They have their parenting mentors in the community. And Jamaica Social Investment Fund should do some of this supporting, and Rise Life Management and NGOs like that can also play a part, have already played a big part. We can assist them how to help those who have specific mental disorders. It could be a little difficult from these typical children. And without psychosocial support, as I said, they might be thinking of feeding their children rather than listening to our lecture about behavior management. So we have to see how we can get different agencies who already have social programs, like for example, Social Development Commission, and PIOJ has something called Community Renewal Program. They should be involved, and the children and the family have to be targeted for support. Definitely preventing trauma will save us a lot of trouble later. And again, different agencies can help us with that. And violence and abuse prevention, we have agents like Peace Management Initiative doing a wonderful job, but the funding and support is dwindling because, again, many of these interventions don't get the impact and recognition they need because it is not integrated. So one agency is providing certain help, like maybe skill training to the parents, where the mental health of the children is not taken care of, or the substance use problem of the brother is not taken care of, who comes and beat up the child, and everything goes to waste. And definitely we have to target those who have been traumatized with trauma-informed interventions. Identifying, screening early can go a long way. And to just give an example, we randomly selected 150 children from West Kingston and gave them a PTSD symptom scale. And 1/3 of them, 58 of them, had full-blown PTSD symptoms. So we have to collaborate significantly with different agencies and ministries who serve these same children. And it can be done. For example, we use an intervention called Bounce Back 1, Part 1, and helped 300 children in one of the primary schools in Augustown by training 20 school staff how to implement Bounce Back 1. And basically they learn psychological skills for relaxation, visualization, affect modulation, and cognitive coping. And the next part, Bounce Back 2, was in progress, where we identified 40 children in the same school with full-blown PTSD, and we are providing trauma-focused CBT in the school setting. We would go there and use the guidance counselor's office to conduct our sessions. And we had a plan for extending that bounce back if they had unresolved PTSD or had other comorbid conditions like ADHD and conduct and so on. As well as the plan was to help these parents and the community members, because the violence is widespread and ubiquitous in that community, with the intervention called Skills for Psychological Recovery. But these steps were interrupted by COVID-19. However, we did do some virtual training in Skills for Psychological Recovery. It was hosted by Greater Augustown Community Development Council, and it was well attended. So if we look, we can find it. Many areas of collaboration and cooperation where we can increase the impact by combining our resources, combining our talents, and streamlining our interventions. So there's no duplication, but there's more evidence-based impact. So you might say, like, how we know what to do, why are we not doing it? Because we are reactive, not proactive. People have to block the road to repair the road. And we have our own daytime job description and workload. And unless we squeeze out some time to do this proactive work, it will never happen, because always outnumbered by the patients we have to see on a daily basis. And it's more difficult for this wonderful 35 clinicians from different regions who have to bear a significant amount of adult population caseload. So they have to really try to give some time to the children. So difficulty in sharing power and visibilities. Some people do it for that. And we are into a competitive mode rather than cooperative mode. We can gather around common goals in these kind of meetings, but sometimes hidden agendas can come in the way and break the union. And that's why it's so important to make it unhidden at the very outset. For example, there was an NGO which came to me and asked me to help some of the children they were targeting in an inner city community. And I told them, sure, but my hidden agenda is, which I'm going to unhidden now, is that you guys need to help us with the community-based stuff we would like you to do, because they're already there. People know them and trust them. And they also told us that we need help because we want to really have an impact so that we can convince the funding agency to continue the funding. And sometimes we go to these meetings and presentations and workshops and we clap, I enjoy the information and experience shared, but then that's where it stops. It doesn't translate into action on Monday. And this is difficult marathon. And unless we are committed and resolved to persevere, we get tired, we get burnt out. And one of the issues also is that there are some large long-term programs like Vision 2030 and Community Renewal Program. And instead of trying to reinvent the wheel, we can align ourselves to those programs and share some of the resources they might provide and provide some assistance to those interventions which can make a better impact. And of course, sometimes support across election cycle is sparse. Thank you. Let it sink for a few seconds. So the youth have given their warning, and it is for us to heed and do something, anything to help. If we again turn our back on them, we cannot complain when they turn their back on us. Thank you.
Thank you very much, Dr. Shetty, for a very detailed and comprehensive presentation. It is very clear that you are very knowledgeable of the situation. And I think we need to make some advocacy for you to be given some kind of job as a child and adolescent czar to promote the well-being of our children, not have you sitting down in clinics all day. We need to get some help for you, Dr. Shetty.
I will take any help I get. Thank you.
Yes. Well, I just want to say to those who are viewing, if you can send your questions in the chat for Dr. Shetty. I have one or two questions though, Dr. Shetty, because we may have some teachers in the audience. Mm-hmm. And so therefore, if I'm a teacher, Dr. Shetty, what can I do to reduce adverse outcomes in adulthood?
Okay. First of all, you need to keep the class interactive and interesting. teachers are in a difficult position. I tell them they do the work of the angels. There's a lot of work, less money, 40 children in a hot classroom. But still, if they don't make things interactive and interesting, they'll lose the audience because they're competing with iPad and Facebook and all that. Second is make class a healing place where you can pause and allow children to express themselves, as well as train them with some stress management skills. In fact, we had some intervention which we are provided to the teachers, which they can apply in the classroom, but also the school-wide positive behavior intervention and support program has a booklet which has some good idea what to do when a child does A or B or C. And soon when this program is scaled up to national level, probably they have access to all those resources. Plus, identify those children who need help, and they can be referred to guidance counselors who are now trained in mental health curriculum. And the others also were trained in it, who can recognize the problem which can be helped in the school level. They call it level 2, or if it is more severe, more persistent, to be handled by a clinician, in which case they refer them to child guidance clinic. So their role is very crucial because that will be first place where children present, and they're missing the both will have disastrous outcome long term. For example, as I mentioned, ADHD will become ODD, will become conduct disorder, antisocial personality, unless it is intervened at some level.
Thank you very much, Dr. Shetty. I have a question here from the audience. In light of what you have shared, what are your thoughts on the mental health impact of online schooling?
Okay, it is definitely not as good as in-person schooling. Although some children who are nervous in the face-to-face classroom find hiding behind the computer more easy, but majority of the children miss their friends, if not teachers, and they miss the football and the liming with their friends during breaks and so on a lot, and that is really a helpful thing for their development and mental health. And now because of COVID, they've been robbed of that, and that's why the parents have to kind of take initiative and make them entertain and make them physically active, so they don't become lethargic, depressed and anxious and so on. And also one of the things I am complained to by the students is, especially in some really high pressure high schools, top schools, is that although the school has started late, they are giving them abundant amount of homework. And in grade 8, they have like 13 subjects. And sometimes it seems the teachers forget that there are other 12 subjects and give so much homework as if there's only one subject for them. And that has put a lot of pressure. In fact, I had to write a letter saying that please give this child extra time to finish the homework, or else they'll feel anxious that they can't finish it, embarrassed and so on. Yeah. So online is what we do now because of COVID, but nothing like school, friends, teachers, all in one place.
Yes, thank you, Dr. Shetty. But I'm also thinking, that in light of the COVID situation restricting our movement somewhat, if we were to abide by the protocols, then it means that parents who should have more time to spend with their children. And, it kind of brings us back to the old days when parents were responsible for most of the things to do with their children. Now we have given it over to the schools to meet all the needs of our children. And so maybe that's the silver lining behind the cloud. I have another question here from the audience. What can I do to become an advocate for children who are made to endure the harsh treatment given by both their parents and their peers? How can I become an advocate for the children who are abused? Dr. Shetty.
Okay. Again, there is abuse of different varieties and different severity, but all abuses have to be reported by anybody who is responsible, whether it's nurse, doctor, teacher, or parent, or guidance counselor, by law. And being supportive of the child, if you happen to be in the sphere of influence, whether it's a church or something, that will definitely help the child to heal. But you have to report the matter to OCR, that's Office of Children's Registry, where they'll log your report, and you don't have to give your name if you're afraid of repercussions of you reporting. Although if you do give a name, they'll keep you informed what is happening with that child, and they will send the information to the Child Protection Family Services Agency, and they will do the home visit, school visit, as the case may be. And in situations where the child's care and protection is questionable, they might even move the child away from the abusive environment and place them in a more supportive environment, whether it's a relative or in some cases foster parents and children. So 1-888-PROTECT is the number you need to call, and you can even give that number to the child to call if they feel threatened and are being abused. They themselves can beg a call from the teacher or guidance counselor and share it with them also and call.
Okay, thank you very much, Dr. Shetty. It's now, well, I think we have time for one more question, Dr. Shetty. It's basically the same format as my previous question. I'm a parent. So what would you advise me? How can I reduce adverse outcomes in adulthood as a parent?
Okay, take care of yourself first, because being in, it depends on how many kids you have and how energetic they are. You might get exhausted being in the same sphere for 24/7, but take care of yourself and take care of them, that's basic. And engage them in activities which are helpful for them to relax, enjoy, and cope with this difficult time where left alone, they can feel isolated and depressed. So we might have to cut down our schedule a little bit and spare that to our children. And not sitting and boring them, but of course, having some interesting and interactive activities. We can play a badminton, football, or play a video game, or just sit and chat about stuff, which might interest them. It's a difficult time for them though, because they have their daytime job, and some of them parents do have some help at home to keep them occupied and focus on the online thing, but others may not have that, and they might just ask a neighbor or somebody to mind them, and children might play video games on the same computer they're supposed to do the online learning. So those things can happen too.
Okay. With online schooling, how do you recognize a child that is depressed or withdrawn?
Okay. They may not be willing to come on camera, and they may not participate, and that is atypical of them. There's some introvert, shy children, they're always like that. They'll probably stay like that unless they get help. But a child who is interactive and participant suddenly becomes less involved in the class, less interactive, then that's a red flag. And just have a little talk after class, ask them to hold on the platform, and probably want to have a word with the parents, because chances are, if not parents, somebody related to the child might be there. At least they can convey the message to the parent to call you. And that way you can find out if they are, feeling sad and miserable all the time, not eating or eating much, not sleeping or sleeping a lot, feeling tired and not focused. And definitely if they're not able to entertain themselves, enjoy the stuff they enjoy. Worse, if they feel, what's the point? Worse, if they feel there's no point in living, then definitely it's time to contact the doctor, and in some cases protect them from themselves too.
Thank you very much. The questions keep coming, Dr. Shetty. I'm very concerned for children whose only safe haven was going to school. Is there any kind of implementation in place to check on these children during this time?
It should be, but I don't think it is there yet. Some schools might have a social worker who might have time and resources to give them a call, especially those who are already known to be lagging behind or not participant or, as they say, troublemakers. So you want to find out how they're doing in the new situation. But also there's a helpline. And the Ministry of Health has a helpline, and there are some counselors who will take calls and make the right referrals. Plus, they can find out about the child, and if there's a red flag, they can even refer them to nearest child guidance clinic. And rule of thumb is any big clinic or hospital, if they don't have a child guidance clinic, at least they know of a child guidance clinic, and they will direct them. And we are doing most of our work on the phone, so it is possible to connect them wherever they are between the classes during lunchtime and such. So we could try to just check on them if they're okay, and if there's need, we'll continue some more sessions with them. And many times I find just having a little chat a couple of times makes them back on track when there's no clinical depression and stuff like that. They're still struggling with the adjustment.
All right. Just a question. You mentioned the helpline, Dr. Shetty, but does the helpline accept calls from children under 18?
I think so. Dr. Laiba, if you are hearing, you can unmute yourself and tell me a little more about that.
Okay, while we wait on Dr. Laiba, this is going to be the last question. Is there any ongoing cross-training for healthcare workers who are trained to work with mentally ill persons who are interested in joining the program you mentioned earlier?
Definitely. The idea was to train the mental health officers and the psychiatric nursing aide to work with the community members with simple interventions, and mental health officers and nursing, mental health nurse practitioners once trained to help the guidance counselors to do some advanced trauma work. And of course, the clinicians, the social workers, psychologists, and psychiatrists will support and supervise them. So that was the training focus, and it was all online. And it was problem-solving model where they'll have active cases under them while they're learning, so they can apply what they learn so they don't forget what they don't use. But it has been postponed now because of COVID, but hopefully we will start it next year. Earlier is better it is.
Thank you very much, Dr. Shetty, for a comprehensive...
Doctor.
Oh, Dr. Laiba, you're here. Before you
Yes,
speak to this, can I just say that when I introduced myself, I didn't mention that I'm filling in for you, who was supposed to have been the moderator. And when she speaks, you will understand why I'm filling in. Go ahead, Judith.
Yes, I just want to say that the helpline will accept calls from children as well, and we'll just direct them accordingly if they need to be directed elsewhere. And that in the pipeline, we're working with UNICEF to put into operation we call a text line, because we know some of these young people like to text as opposed to really talk. So we're trying to give them more access so that they can, sound the danger bell if they feel in distress or they're in danger. Thank you.
Thank you very much, Dr. Laiba. Still working in spite of everything. Okay, so we are going to move on now to our panel discussion. So stay on the screen, Dr. Shetty. Sorry. Okay. Oh, sorry. Yes. I'm being reminded that there is a video that follows this presentation. And after the video, we will have our panel discussion. Thank you very much.
Hello everyone, my name is Jody Marie. The Ministry of Health and Wellness, in collaboration with the University of the West Indies Mona, Western Jamaica Campus, Psychology, Sociology, and Social Work Department, welcomes you to Mental Health Week 2020. This year's theme is Investing in Mental Health. The time for action is now. It is never too late to do something. As we all know, this year we have all been affected by the new coronavirus. We have all been displaced and we have all been affected in some way. We decided to speak with some of our parents and children to get their perspective and understanding, as well as the challenges that they have been facing due to COVID-19. Good morning.
Good morning.
Can you introduce yourself, please?
Okay, my name is Yakisha Slowly, mother to Imari Jarrett.
Okay. Hi, Akisha. Do you have any more children?
I have another child. Yes, I do have another child.
Okay. Can you tell us the ages of your children?
Okay, so Imari is 6 and my daughter Kayleen, she is 4.
Okay. Okay. Can you tell me, Yakisha, how do you feel about the coronavirus?
Well, honestly, I think Corona has become such a nuisance right now in my life. I wish I could just blink and it's all over.
Mm-hmm.
However, that's not the case for now, or it seems like it's not going to be the case for any time soon.
Mm-hmm.
But it has made life a lot more difficult.
Mm-hmm.
However, I am learning to cope.
Mm-hmm.
I am learning to cope. And,
Okay.
Yeah.
Okay. What are some of the challenges that you have personally faced due to the coronavirus?
Okay, so in terms of challenges, I would say I was working from home, and while working from home, I thought it would have been glorious. However, once home, I realized that it was very hard to compartmentalize my life.
Mm-hmm.
Everything was all in one space because I'm a student. I'm a mother, and I work, so I play different roles. So with everything being in the same space, it was very hard to manage. I couldn't wait to go back to work. Once I'm now at work, it's even harder because well, it's not so much harder per se, but we have to be in a mask constantly. We have to be sanitized at every angle where we go. Anywhere we go, we are only allowed to remove our mask when we're eating. So it's very hard, to be in a mask all day working. There are so much restrictions at work, seating arrangements. You're far away from your colleagues. You can't talk to them. So yeah, it's not so much, well, as it pertains to me traveling to work, that's not so much of I am glad I don't have to, what should I say, come in contact with a lot of people. So I'm still keeping socially distanced. So I'm grateful for that part.
Okay. Wow. What are some of the challenges that you have faced as a parent, specifically because of the coronavirus?
Okay, so as a parent right now, it's very hard as it pertains to online schooling when I'm now at work. So it increases your budget that you have to spend for school, in terms of you have to try to find someone who is available to stay with the child while the child has online school. As for me, I have to have Imari currently doing online school for himself because there's nobody here to monitor him, right? So I have to teach him all that he needs to do to go on his classes and everything. I have to keep calling his grandmother, who is not technologically savvy. I have to keep calling her to tell her tell Imari to go on class or tell him to go on Google Classroom. I have to tell my mom to have him do these things because we don't have anyone available to stay with him, right? So if school was in process, we wouldn't have this challenge, but no, it's much harder knowing that we as the parents have to be here physically with the children to help them because really they don't understand. Most do, but I would believe it's the older children. The younger children, they don't understand how to really maneuver these technologies. So it's a little bit harder. And I believe it's harder on the teachers as well, as most of them aren't really sure as to what they are doing, in all fairness.
Wow, there's a lot of displacement, so I can definitely understand the challenges. So with all these different challenges and roles that you have to play, how do you cope with the stresses of being an adult, a parent, and a student? How do you cope?
Okay, no, I'm a big advocate for my mental health. So if I feel as if I need to stop and take a break, I am going to stop and take a break. So if I feel like it's too cumbersome, I'm going to stop. So I do stop whenever I feel the need to stop. And of course, I get enough sleep. So whenever I need rest, I get enough rest to try to overcome these challenges that I'm going to face. Because, I have to wake up early, get them ready and stuff like that. So I have to get enough rest. At work, I drink a lot of coffee to stay awake, honestly. But it's definitely whenever I get a chance, I sit and relax and watch a TV, have fun with my children, play with them, talk with them, and stuff like that.
Okay.
Yeah.
Okay. Thank you so much for speaking with me, Akisha. Hi, good morning.
Morning.
What is your name?
Margaret.
And how old are you, Imari?
6.
Good. How do you feel about COVID-19?
I
What?
feel bad
You feel bad? Why do you feel bad?
because the COVID-19 kills a lot of people with the coronavirus.
Okay, because COVID kills a lot of people and makes them sick. Okay. How do you feel about not going to school because of COVID-19?
Because the coronavirus.
Right, because of the coronavirus, how do you feel about not going to school?
I feel very bad.
You feel very bad? Why do you feel very bad?
Because I didn't want to go to school, but I have to go on Zoom school.
You have to go on Zoom school, and you don't like, it doesn't sound like you like Zoom school very much. No. What don't you like about Zoom school?
Because it makes horrible sounds.
It makes what?
Horrible sounds. That's why I cover my ears.
Okay. How do you protect yourself from the coronavirus?
Wear a mask.
Okay, very good. Is there anything else that you do?
Take a bath. Wash your hands.
Okay, very good. And what are some of the fun things that you do that you don't get very stressed out by the coronavirus?
Yeah.
What's that?
What are some of the fun things?
What are some of the fun things that you do to not be so stressed out by the coronavirus?
I watch the TV.
You watch TV. You watch TV and what?
I don't Why are you looking
You
at
don't
know?
What are the fun things, since you have to be at home so much, what are some of the fun things that you like to do at home besides watching TV?
I like to watch TV. No, I love to play inside. And my cousin love to do it.
I'm
Yeah.
not hearing you, Mari.
I love to play with my cousins and friends. But I can go upstairs and go to my very best friend.
Okay.
I
Oh,
can play with his tablet, or he can use his phone.
okay. Okay. Very good.
He's 7. He's 7. He was like 6 like me, but he turned 7 because it was his birthday, October 2.
Okay. His birthday was October 2. Okay. All right. Thank you for talking to me, Mari.
Welcome.
Good morning.
Good morning.
Can you introduce yourselves, please?
My name is Liana Morris, and this is Alex. Alex,
Hi,
what?
Liana.
Jason Dunn. Okay.
Hi, Alex. Hi, Liana. Morning again, Liana. How many children do you have?
One. Only me.
Only you. Okay. What are,
Still have a cousin. I have. Okay. Enough information.
what are some of the challenges that you have personally faced, Liana, because of the coronavirus?
Well, apart from his schooling and having to, well, I already had the means of him doing online schooling, but for him to actually grasp online classes, that was something. But apart from that, with him, there's not much of a challenge because he's always home. For myself, though, I'm quite apprehensive of being around a lot of people because of the whole pandemic, which is quite understandable regarding what is happening right now. So anybody would be apprehensive. But my work environment is just the same, other than I hardly take in face-to-face persons, but that's it.
Okay. Can you talk a little bit more about what the challenges are that you've been facing as a parent due to COVID-19?
Well,
Grandma,
there's extra spending, to tell you the truth,
Okay.
because I have to know that behave, young man. Right. There's extra spending because I have to make sure that there are means and ways for Alex to be homeschooled, as I said before. What else? Well, my brother is always home with Alexander, so there is not much of a challenge that I face per se if he wasn't going to school now, because he's actually going to school as well. So he's home with Alex and he's doing homeschooling just the same as Alex. So I guess it's a plus side for me there because there's always somebody at home with him and somebody there to help him. So there is not much of a challenge on my side where parenting is concerned. He's always home.
Okay. How do you cope with COVID-19 being such a prevalent thing right now?
Well, I'm not so much of a social butterfly, so apart from recreational activities and then the fear of coming into contact with some persons who are in fact infected and do not know because they probably are asymptomatic, that is a fear that I often face day to day because I deal with persons, I get in documents, and we know that the virus can travel on anything. Um, I even went through to the distance of saying, all right, this thing is getting serious. It's time to get our own vehicle to go where I want to go, and so it limits my exposure.
Okay.
So,
Okay. Thank you for that. Where is Mr. Alex? Hi again, Alex.
Hi.
Can you remind everyone how old you are?
No.
6. Okay. How do you feel, Alex, about the coronavirus?
Free.
you're afraid.
You're afraid.
Why are you?
Because I don't want to get sick.
You don't want to get sick. What usually happens when someone gets sick?
They need to go to the doctor.
They make them go to the doctor. Okay. How do you feel about not going to school because of the coronavirus?
Scared.
You feel scared? Why do you feel scared?
Why do you feel scared?
I still don't want to be sick.
Because you still don't want to be sick. Okay.
Okay.
Yeah.
Do you like
And
online school or do you prefer going to regular school?
online school.
Do you like online classes with your teacher?
Of course.
You like it? Why do you like it?
Because
Come on. Why do you like it? Take your hand from your face. Take your hand from your face.
it's just my other eye was blocking.
Okay, why do you like online schooling? Why do you like online class with your teacher? Don't you want to see your classmates? Hmm? Alright, so you see how he's behaving, Shy? This is how he behaves with his teacher. The first time he met her and his classmates, he tends to shy away from talking to them because he doesn't know them.
Okay.
So that's a challenge that I face with him and online school. He refuses to talk unless he is comfortable or he knows the person that he's talking to.
Okay. Has he gotten a bit more comfortable with the classroom, the teachers and the students know that he has been going to school for a few weeks?
A little, yes, he has,
Okay.
but not to the point where he would talk to a family member or myself while he's on a video call or other media.
Okay. I can definitely see how that would be a challenge for learning. One final question, Alex. What are some of the fun things that you do to not become upset or stressed out by the coronavirus?
Dancing. You can dance.
Nah.
You can tell her that you plan to pee.
What?
Remember that you set the peas to grow.
Of course.
Yes.
They're good.
Can you tell me one
What
other
else?
fun thing?
I used to play.
You used to play? You don't play anymore?
Yes. Of course.
What do you do? What do you do?
My toy truck.
Your toy truck.
Okay. All right. Thank you for speaking with me, Lena and Alex, and enjoy the rest of your day. Good afternoon.
Good afternoon.
What is your name?
My name is Yuri.
Hi, Yori. How old are you?
6 years. I am 6 years old.
Nice. How do you feel about COVID-19?
I feel bad,
Why do you feel bad?
and because I never get to see my friends.
Okay. How do you feel about not going to school because of COVID-19?
I'm bad
Bad? Why is it bad?
because I never get to see my teachers too.
Okay. How do you protect yourself from COVID-19?
Wearing a mask and washing my hands.
Very good. Is there anything else that you do?
Don't go to places and trouble stuff that are outside on the road or houses.
Very good. Very good. How do you cope with COVID-19? What are some of the things that you do to cope with COVID-19?
What is cope? I don't know cope. I don't know.
With COVID-19, what are some of the things that you do to make yourself feel better?
Give my toys.
Very good. Okay, is there anything else that you do?
With my brother.
Very good. Thank you for talking to me, Yori.
Bye.
Thank you very much, everyone. Next, we have a panel discussion. Can our panelists now join us? We have Dr. Clover Hamilton Flowers from the Ministry of Education. We have, we have Dr. Ganesh Shetty, our speaker. Mrs.
Can you hear me, Dr. Bernard? Can you hear me?
Hearing you now, Doc.
Okay, good. I switched to my headphones.
Okay. And we have Mrs. Yuki Atkinson, Research Analyst at National Council on Drug Abuse. And we have Miss Joy Chambers, Coordinator, Adolescent Services, Family Health Unit, Ministry of Health and Wellness. And we have Dr. Abigail Harrison, Consultant Pediatrician, specializing in adolescent medicine. I have a little information about Dr. Clover Hamilton Flowers. She is an educator and her focus is on curriculum. All right, now the plan was before the COVID outbreak hello, one speaker at a time, please. Yeah, the plan was to give each panelist, the topic we're going to discuss is charting the pathway to improve child mental health. And the plan is to give each panelist 5 minutes to do a short presentation on their take on charting the pathway to improve child mental health. And the end of that, we will have question and answers. We are running a bit late, and so we will probably end up finishing the presentations at 7:05, and then at that time we will see how much time we have left for questions. So can we start with the first panelist, Dr. Clover Hamilton Flowers? Are you ready to go?
Yes, thank you.
Okay, your 5 minutes begin now.
Okay, good afternoon, everyone. It's a pleasure to be a part of this discussion. And given the timeline, I'll just get right into it. I just want to clarify for myself and for all of us to be on the same page. some concepts that I've seen, you know, jumping out at me in terms of the topic. And I think I'd want to maybe pay a little bit of attention to what mental health is about from my perspective, given what the curriculum or what teaching and learning would be centered around. So while perhaps persons will think about it from a position that you're free from illness, I probably want to look at the kind of experiences that individuals are having. So in terms of the child, the nature of the experience, you know, that feeling of wholeness, feeling safe, feeling as though I can manage what is happening to me relative to the situations, circumstances, the relationships, you know, with family, friends, teachers, as we're hearing some of the children saying. It's also important for us to consider that when we look at the human architecture, we're looking at the child, we want to consider to this whole person. So we speak about mental health, but it is so important to look at how we have been designed, where body and soul and spirit are supposed to be working in harmony. So when something is off with one, we can end up with problems in another. In the context of education, we'll oftentimes talk about this by saying we're catering to the development of different domains of development. We're looking at how the child is thinking, we're looking at, you know, the physical aspect, and we could go into this long list. But it's important for us to be mindful of that. So if we're gonna be charting the way, a way forward relative to our pathway, I would want us to be mindful of the fact that we must take that kind of holistic approach. We want to look at it to make sure whatever is being done is relevant to the individual, as opposed to us concentrating a lot on the group. We want to ensure that we have sufficient information about that individual. So we'll talk about the person's profile, and many times when we think about the profile, we might limit that to just physical health or academic performance. But we also want to look at the whole child in terms of even the background, what's going on relative to family situation. We want to pay attention to purpose. Is it that the family feels that this child has some great purpose in life, and you know that child is also aware that, hey, this is how I'm seen in my family, that I am somebody who is special, I'm treasured, and that kind of thing. We also want to look at, just like somebody just said in sharing about voice, this child, for example, needs to feel comfortable in the space, but what was positive about that interaction was the child was given voice. So I want the child to be able to speak, given a voice, multiple avenues for self-expression, paying attention to gifts and talents and creativity, you know, to take away some of the burden of learning and education being just centered around trying to pass tests. So when we look at the profile, we want to move to customizing a program. It does not have to be anything complicated for this child. And when we're actually making use of this program, we also want to ensure that all of us enter into a space where we are holding ourselves accountable for what is happening where this child is concerned. So we want to think of it in terms of community, technology, making sure that entertainment is also educational, connecting the things in a fun way. We want to look at some of the activities at home, how these can be used again in a fun way to help children to learn. It needs not be difficult. Speed games, thinking outside of the box to do just some little activities, pacing things so they are manageable, giving opportunities for creative construction. And guess what? Children learn a lot through play. Physical activeness is important. Lastly, I want us to be mindful of the spiritual aspect. How do we nurture the child's spirit? Do we provide opportunities where the child feels hopeful about things? You know, that kind of optimism that we want to be encouraging, you know, making mention of those positive qualities that we're seeing and making big these positive qualities, as opposed to making big the things that we are uncomfortable about when we make some observation. So being purposeful, giving opportunities for the child to experience success, ensuring that things are being paced in a way that the child can cope, would be some of the things that I'd love for us to be mindful of, even as we think about charting the way for as a pathway for our learners to be mentally healthy or to improve mental health.
Thank you very much, Dr. Hamilton Flowers. Dr. Shetty, your 5 minutes begin now.
So my colleague, Dr. Harrison, I really enjoying listening to the ladies, and thank you, Mrs. Flowers. It was quite heartening. You're there?
I am.
Go ahead, please.
Could you share, you're handing over to Dr. Harrison?
Yes, please. Yes, please.
Okay.
Okay. Hi, thanks, Dr. Shetty. Dr. Bernard, is it that you want me to just go ahead?
Sure, go ahead.
Okay, all right. So I had been advised to put together some slides, so I'm just going to do that if that's okay.
Okay.
All right. And if you could just confirm for me that you are seeing my slides.
Confirmed.
Perfect. Okay. So afternoon, well, no, it's not afternoon anymore. I think we're squarely over into evening. So I wanted to just quickly, review what we're seeing now. I think a lot of it has been said already, but essentially the concern for me, and I am sure for many of the persons who are watching, is that we're seeing increasing numbers of children and adolescents who are having mental health concerns. And certainly more of them that are having poor coping strategies. There are many parents who are unsure what to do and how to help. And many parents who may be clueless to what's going on, because I found that young people are particularly good at hiding what they're feeling, because oftentimes they don't think anybody wants to hear. And then, we've been having a lot of things through the MOHW talking about stigma, but it really persists, and hopefully we can do some more work and make that change. And then of course there's COVID-19. And basically for me, I think everything just turned up. So it is stressful. All right, so this is what we're hearing, especially from our young people. How long is this going to last? When is school going to start back? And then, as Dr. Shetty mentioned, those who are, maybe anxious about appearance, do I have to show my face online? We have free exposure and untenured exposure to online risks, increasing visualization of porn. Then we have those who are afraid to leave the house because there's so much anxiety around COVID, and because, just the fear of what will happen if they get it. And then recently, I've been seeing quite a few of the younger ones who are just starting a new space, who, for example, are going to first form in a new school, and they don't really know anybody in their class. And how do you make friends when you're online in a class and the teacher doesn't allow you to talk and to chat, right? So all of these have been included: depression, anxiety, self-harm. I'm sure most of the persons who are online watching this are aware of the increasing numbers of young people who are cutting or using other sorts of self-injury behaviors, who are making unhealthy choices around substance use and risky sex. And I forgot to add here, but one of the other things we're seeing is a lot of control being put into how young people are eating. So we're seeing an increase in the number of young people who are exhibiting disordered eating behaviors. And some of those will continue on to have an eating disorder. And that is just a really challenging illness to work with. So how can we help our parents? Some of this has been said, but I want to just highlight them. I think we need to listen to our young people. Oftentimes we'll tell them we're busy or we're tired. And sometimes we may be genuinely busy, but if they came to us, then you make sure and go back to them and said, remember I said I'd come to you as soon as I'm finished, and here I am now. Don't ask them how they're doing if you don't actually want to hear. And when they start to talk to you, don't complain about the timing. Just say, oh, wonderful, they're talking to me. And at all times, try to be supportive. What I like to remind parents is don't preach at your kids, they get enough lectures at school, You don't need to preach to them, but you do need to help them to learn to think on their own feet, so they can make their own decisions even when you're not there. We need to focus on their strengths. I think Mrs. Clover Hamilton, Dr. Clover Hamilton said that earlier. And then, boost them up, make them feel good. We always talk about grades, but we don't talk about some of those other character traits that we want them to have: integrity, persistence, kindness. And I think if we tell kids that they're not going to come to anything, instead of living up to our expectations, they will live down to our expectations. So that really is one of the key things. One of the challenges I find is that a lot of our young people don't actually know that their parents love them. So, when I say that, but, of course your parents love you, they're like, well, you may think that, and you may think that's what's supposed to happen. So make sure you tell them, make sure you show them. Make sure you also help them to look beyond just immediate gratification sometimes and look further down the road. This is, building that character. Be a good role model for them so that they also will be able to choose role models. I think one of the greatest things would be when your child grows up and when they're asked who is your role model, they can say their mom or their dad or their guardian. I think that, that would be just the perfect thing. And then remember also, this is difficult in Jamaica, but I think we have to remember that discipline should be for teaching and not for controlling our child or our adolescent. And don't fluff it off or diss them about the things that they say are their concerns. And when they look sad, looking at them and telling them, how much you have to be happy for in life and how blessed you are. Yes, but don't use that as a cursing word. If they're sad, then they should be able to be genuine with their emotions and what they show. And as Dr. Shetty said, if you see concerning changes in your child, then get help. So if there's sleep disturbances, if there's a change in their appetite, if they're having more headaches all the time, if they're constantly exhausted, they're having tummy aches all the time, you have to look at that. If they don't want to leave the house, if they're more irritable, every little thing bothers them more so than the usual. If they don't want to be around friends and family, any uncharacteristic behavior. As healthcare providers, for those of us who are in the audience, we need to ask about changes in mood and behavior. Don't wait on the parent to tell you or the young person, because they're not gonna. We have tools that we can use to look for anxiety and depression, and the ones that are highlighted are the ones that are validated in our population. But if you don't have a lot of time, sometimes just 2 questions on depression, 2 questions on anxiety are enough. Ask for and look for evidence of self-harm and guide the young person on how to cope. And if you don't think you're good at that, then refer them. The earlier, the better. And I like to say prevention is better than cure. But if your child is diagnosed with a mental illness, don't be afraid. Most of them will do perfectly well with appropriate management, and you just have to support. So we need to open our minds and hearts to the realities that mental illness is here to stay. It's increasing because our world is just a lot crazier, but we need to be wise in our approach, regardless of what perspective we come from. And we need to be kind to one another. And if we use those 3 tenets, then we can stamp out the stigma associated with mental illness. So I hope I was in my 5 minutes, Dr. Bernard.
No, you have taken yours and Dr. Shetty's 5 minutes.
Oh, you're so bad.
So I'm going to ask Mrs. Yuki Atkinson, Research Analyst, National Council on Drug Abuse. You see, I'm going through the list, so I hope you're ready, Mrs. Yuki.
Yes, sir, I am ready. Thank you very much. Just about to put up my screen and try to follow Dr. Harrison's example and bubble through very quickly. So thank you for the opportunity to share NCDA's perspective in terms of charting the pathway to improved child mental health. For us, one sec. Are you seeing my screen?
Yes, we are.
All right, thank you. Okay, so what are we improving? For us at the NCDA, we're looking at the issue of drug use among children and adolescents. What we know from our studies is that, successive studies have shown an early onset of drug use in terms of an average age of 12 to 13 years. the fact that 1 in 5 who currently use these substances are at risk for further misuse, and the issue of easy access, the issue of suicidal ideation. These are things that we've seen in recent studies. And then the contextual factors such as the parenting and home environment, which can, cause exposure, changes in attitudes and so on. Cultural acceptance broadly, there are poor coping and life skills, which was already mentioned by previous speakers. We also have some emerging threats in our environment with low risk perception of edibles, so that, young people are now feeling like if you eat ganja, it's not as bad as if you smoke it. The issue of e-cigarettes and vaping is also something that is emerging in our environment. And so these are some of the things that we're targeting, trying to lower risk factors that exist and increase the protective factors. Now, a number of these risk factors were already spoken of, so I will not list them, only to say that we try to focus on the things that are what we would call the low-hanging fruit, the things that we're able to impact. So we can't impact poverty, we cannot impact drug availability as an agency or as helping professionals, but we can impact things like coping skills and risk perception and participation in pro-social activities and so on. A recent assessment that we did in 165 schools among mainly guidance counselors showed that their number one concern and priority was for parenting interventions, followed by things like, providing presentations on drugs, as well as increasing teacher capacity to deal with the issue of drug use. Now, this was all said already in terms of the family-based prevention and what needs to be incorporated. What I would like to highlight here is the importance of sensitizing parents on what the impact of exposing children to drugs at an early age would, the significant impact it can have. And we would all be aware of the recent issue with the young child, the 3-year-old from Clarendon. Sad to say, yes, this was something that was widely, televised and so on and broadcasted and so on. But this is something that occurs across the board, across the island, not on a large scale basis, but it does exist. So, and it's not only, the fact that these parents, yes, they are, not responsible enough and all of those things, but this is something to do with cultural practices and beliefs that, the earlier you start, it means that you are able to handle your liquor and so on. We don't typically see 3-year-olds being encouraged to use substances, but we have seen young children encouraged. So educating our parents is something that's very important. And then we have prevention programs at various levels of the developmental cycle. So at the early childhood level, you want to focus on things like self-control, emotional awareness, build those kind of skills, because those are protective factors for drug use later on. And then to be able to identify early factors such as aggression and academic failure, if there's poor school attendance, these are the things that we look out for. And of course, to build teachers' capacity to be able to screen and intervene at these stages. In the adolescent phase, again, skill building is what we try to focus on. Increasing knowledge alone will not change behavior. It will not impact the likelihood that young people will or will not use substances. But when we focus on things like skill building, such as problem solving, coping, how to deal with stress and so on, because we find that majority of our young people who advance to problematic drug use, they're doing it because they don't have an ability to cope very well with problems in their lives. Peer-led interventions is something else that we do very frequently at the agency, because it is, when we talk to young people as adults, it may not come across as effectively as when their peers speak with them. So we build the capacity of peers to be able to intervene. And then with teachers as well, what we're doing, we recently completed an online, of course, everything is online now, training of 440 professionals from the Ministry of Education. These are guidance counselors, HFLE teachers, and deans of disciplines to be able to screen, provide brief intervention and referral to treatment for for specialized services if this is necessary. So the more we have persons on the ground being able to identify risk factors for drug use and also the signs of drug use among adolescents, some of which Dr. Harrison just outlined in terms of changes in the behavior and friends and withdrawn or aggression, etc. The more we have our professionals exercising these screening and brief interventions, not only in the education system, but also in the primary healthcare setting, is the more likely we would be to prevent problematic drug use later on. One other thing we do is include youth in our prevention efforts. So all these pictures that you're seeing on the screen show youth ambassadors who have been to Vienna at the UNODC's International Youth Forum, as well as locally, young people who have gone into schools. They've been trained and they go into schools and do prevention programs with support from structured evidence-based prevention program material. At the community level, as Dr. Shetty said before, there is need for us to combine our efforts. So we don't want to be working in silos that, there's one person doing something here and there, etc. But to combine our efforts to be able to intervene at the community level. What we do in the communities, we increase awareness on the harms associated with drug use, and then encourage communities to come up with their own strategies. When it is bottom up versus top down, you get more out of that. So strategies that they have come up with include things like, okay, we're not selling to anybody who is, no alcohol sale to children younger than 18, or nobody's going to any dance in this community and community members enforce it versus, a law enforcement approach and so on. So these are some of the things that we do. And of course, we're trying to attempt to have drug-free school zones where at the school gates and surrounding environs, substances will not be available to young people. Again, prevention, as Dr. Harrison just said, is much more effective and efficient, but there are instances where we need to deal with treatment of adolescents with substance use problems. And so we do also provide specialized treatment, and there are a number of things that have to be considered in terms of their frequency of use. Do they have other medical conditions, readiness for change, and a number of those other things. I want to end with this encouragement for everybody online to be able to participate in a national survey. It's actually a hemispheric survey led by the Organization of American States, which is looking at the impact of COVID on substance use, the impact of COVID-19 restrictions in particular on substance use in Latin America and the Caribbean. Jamaica is one of the participating countries. You should see the link being uploaded now. And what we're asking you to do is complete the survey, 1, and 2, to be able to share it with your networks. Because while we understand that this is not going to be representative of the population, and we can't say that this is what is happening across the island, etc. What we want to do is have an indication of how people are responding to COVID-19. And there are some other mental health questions that are included in the survey. So we ask that you participate and you also share it with your networks as widely as possible before October 20th. Thank you very much. How did I do with time?
Excellent, excellent. And we are going to move straight into Miss Joy Chambers, Coordinator of Adolescent Services Family Health Unit, Ministry of Health and Wellness. Miss Chambers.
Sorry about that, Dr. Bernard. I'm sorry about that, audience. So I want to look at some of the activities that we're currently doing at the Ministry of Health. In terms of service delivery in the in an adolescent and friendly environment, the Ministry of Health and Wellness has developed some protocols in which to deliver services to adolescents. And so we developed 10 standards and related criteria to do this. These standards and related criteria were developed as a guide for ensuring quality services, and these include adolescent health services in a supportive environment. They ought to be affordable and accessible, support client rights, and ensure that there's adequate physical and psychosocial assessments. So we currently are implementing these standards in at least 44 health centers island-wide, and we have these in at least 3 per parish. The clinics are accessible by adolescents only at varying times. So for example, they could go on a Saturday morning from 10 to 2, or a day per month, or extended hours in the afternoon. Adolescents are able to access the basic minimum package of services that are recommended in these standards and criteria manual. And if the services are not available, then the appropriate referrals are done. So we've established a teen hub in the Halfway Tree Transport Center. This was done in 2017, and it's really a non-traditional access point where youngsters can access clinical, educational, and social services. And so we have our youngsters coming from school at 2 o'clock. And so they would come to the hub, do their homework. If they have SBA preparations to do, they'll do it there. We have a BizHub printer so they can print their assignment, and this is free of cost. We also, the services that we offer at the hub includes HIV screening and counseling and tests, pregnancy screening, mental health screening, counseling and referrals, group and individual counseling, weekly visits by mental health professionals, career guidance, skills training, and of course, as I mentioned earlier on, assistance to do their homework and school-based assessment. And for those who are just about exiting school, we assist them with resume writing and help them with their job search. So for the last year, 2019, between January and December, approximately 7,751 young persons access services at the hub. And over 7,000 have accessed skills-based training, mental health services, career guidance, and of course, pregnancy and HIV prevention and education. We've tested over 879 young persons, and these are in the age cohort 16 to 24 years. And 45 youngsters have received mental health therapy. We're now training 60 adolescent advocates and peer mentors, and they've been trained to generate feedback, provide input, and deliver basic information among their peers. So what are the lessons learned from establishing this teen hub? We know that adolescents are not naturally drawn to health facilities. So of course, they require this non-traditional approach to access healthcare. And in that vein, we're establishing 2 more of these teen hubs between now and the middle of next year, because we have now gotten funding from Spotlight, this European Union project. So we are hoping to put 1 more teen hub in St. Thomas and 1 in Westmoreland, because based off the figures that we are generating from the existing teen hub, we see a need for this. That's not to negate the fact that we're not promoting our adolescent clinics, because for those youngsters who are in the rural community, we ensure that they do access the services there. And team have been trained specially to deal with this subpopulation, because we know the group is diverse and they come with their own sets of challenges. So another thing that we've learned too is that adolescent participation is critical in the design and planning of any program that affects them. And so prior to establishing this hub, we had our baseline assessment and we had focus group discussions with them, and they told us what it is that they wanted. And I believe this is why the hub is such a success. And so that is where I leave. So I hope I've done my 5 minutes.
Thank you very much, Miss Joy.
Was I in the 5 minutes or was I?
Boy, me wasn't watching it, you know.
You're much too kind.
I just want to take this opportunity to acknowledge to big up some very important people in our audience. I just want to say, you know, welcome to the Director of Mental Health and Substance Abuse in the Ministry of Health, Dr. Kevin Goldburn. He is in the meeting. Probably he should be doing a panel presentation as well. And also want to recognize Dr. Michelle Harris, who is an advisor of non-communicable diseases and mental health at PAHO. So this must be a very important meeting. Okay, now it's question time. I know that it's 10 minutes past 7 according to certain, well, actually it's 7 minutes past 7 according to certain clocks, and we are supposed to close at 7:10. But however, we know that we are living in Jamaica, and I'm sure there must be questions in the audience. And so we're going to give an opportunity for, well, I'm going to open it up to say not only questions, but if anybody wishes to make any kind of comment, for example, any of those two persons that I said hello to a while ago, or anybody else would like to make any comments or contribution. So the floor is open for questions and comments.
Dr. Bernard, this is Dr. Michael Harris. I just want to take the opportunity to commend the team for an excellent panel discussion and the presentation and the videos, and to commend you to continue the good work that you're doing to address the needs of the children. Thank you.
Thank you, Dr. Harris.
And I would like to just underscore what Dr. Harris said about the excellent presentation, and hoping that as time goes on, we can get more people specialized in child psychiatry. I know many persons who do medicine don't like pediatrics and child psychiatry, but the more we have there is the more we can do as a preventive work, so persons don't have to grow up into adulthood and adolescent with mental health issues. Great job, all presenters and moderator. Thank you.
Okay, Dr. Goldburn, Dr. Harris, thank you very much. We have a question that's not directed to anyone that we would like the panel to weigh in on. How do we support parents during these difficult times? How do we support parents during these difficult times? Anyone from the panel?
You can do what you can to support. If you can, you emotional support, you have time, you have way to communicate. Just knowing that somebody cares enough to call or check on somebody who is stuck in the house will be great. And these are difficult time for many parents. Not everybody has gotten a free tablet, for example. And if you have one spare at your house, you can dispense, then that would be great too. So there's something you need to look at how you can help. It could be emotional, it could be financial, it could be putting them in touch with some of the resources, because some of the parents don't know that Ministry of Education is offering this or that. Just to get them to know where to call, who to ask can go a long way. Just being there for them means a lot too.
If I may comment, there is the National Parenting Support Commission, and they have like help desks, so parents can actually call in to let it be known in terms of challenges they're encountering. So when some of the challenges are concerned with like learning or curriculum, usually the curriculum unit would be called upon to provide some help there. Schools too should have what is called curriculum implementation teams, and there should be a parent representative on that team to help parents to work together to support each other. So those are just some of the things already in place that could assist parents.
Just to say also, if I may, that the NCDA also has a helpline, 564-HELP, 564-4357. And what we've seen over the past 4 months, 3 to 4 months, is a significant increase in the number of calls. So persons are expressing, parents as well, you know, the difficulty that they're facing. A number of them are relapsing. And what we've seen, I mean, Mr. Tucker spoke about this in the opening, and the next day there was a headline about, you know, alcohol use increasing. He actually never spoke about alcohol use increasing, but what we're seeing is that 70% of the persons who are calling about problematic cannabis use. And so it might be an indication. I mean, we can't use that to say that cannabis use has increased. That is why we're doing the survey. I think another thing that we can do is tell people about self-help tips, self-care tips, because some persons, you know, don't feel comfortable enough reaching out to established helplines and so forth. So simple things like daily exercise and meditation and staying close to family members, going outside, taking a walk. I mean, just very simple tips that can help people to feel better in these uncertain times.
Yeah, I'm going to take another question. And this seems to be coming from somebody who has interest in St. Anne. Is there any consideration for one of these teen hubs to be established in St. Anne? Joy.
Absolutely, but just not at the moment. Unfortunately, Spotlight, who is going to be funding the establishment of these hubs, have identified 4 risk parishes, which would include St. Thomas, Westmoreland, Clarendon, and Kingston and St. Andrew. So regrettably, not for now for St. Anne. However, our minister is invested in these teen hubs, and he has asked that we establish 1 per parish. So in due course, St. Anne will be next in line, because they've actually gone ahead and have done their baseline assessment. They've met their young people. They have actually identified the site where they want to put the hub. They're looking at a very central area in Ocho Rios. So St. Anne's time is coming. And I want to use this opportunity to thank Dr. Shetty and his team from Child Guidance and Dr. Leiber for ensuring that we have mental health services weekly. Well, daily, but certainly we have mental health professionals who come into the hub weekly to ensure that the requisite counseling and screening and referrals are done. So big up team.
Thank you, Joy, and I'll convey that to my team.
Always, always.
Okay, and a note here from Clover Hamilton Flowers. I think everybody can see it. Guidance, counseling, and special education units also offer support to parents, I believe. Okay. And so at this point, we're going to thank everybody for participating. We're going to thank our speaker, our panelists, and the organizers, everybody who worked hard to bring this thing together. And I hope that this conference, the information that we have shared, will be disseminated to where it is needed, and that many of the ideas that have been discussed will come to fruition not very long from now. So I just want to thank everybody for participating, and it has been a very good and efficient meeting. And it was my pleasure to be the moderator. So thank you very much. Good evening and good night, everyone.